Okay, so should I start, ma'am?
Yes, perfect.
You start, yeah. Introduce and that.
So, good morning, everyone, and welcome all of you to this MRA educational platform, virtual platform. I'm Dr. Bhatt, and for the first time, we'll be having a journal club for students and fellows today. And this is actually one of several that we are going to start now. We are hoping to have this as a quarterly exercise every 3 or 4 months. Because I think journal clubs are important for the students and also for us to stay abreast of the latest research papers and also how to, to know about various trial designs, study designs, critical appraisal of the evidence and research into our daily practice. So I'm sure this would benefit not only the students, but also all of us. So I have with me co-faculty for today, Dr. Sushant Shinde and Dr. Sanath Phatak. Dr. Sushant Shinde is consultant rheumatologist in Rheumaderm Clinic and Quest Medical Academy in Bombay. Has he joined us, Sushant?
Yes, ma'am, I'm there.
Yeah, hi, Sushant. Good morning.
Yes, sir. Good morning.
And I have with me Dr. Sanath Phatak. He's a consultant rheumatologist in KEM Hospital, Pune. And they would be helping to moderate this discussion of JC today. And the paper we've selected for the JC is Bliss Belief Study in Lupus. Our presenter for today is going to be Dr. Ashish Agarwal. Dr. Ashish is second year DRNB resident in Hinduja Hospital, Mumbai. Dr. Ashish?
Yes, ma'am.
Yes. So I think without further ado, we should start the presentation of the journal.
Thank you, ma'am. Yeah. So I'll be presenting the journal club today, which is on the Bliss Belief Study. So let us first go through the basics. Rituximab is an anti-CD20 antibody. The CD20 receptors are present on the pre-B cell, the immature B cell, and the mature B cell. Rituximab, by inhibiting these CD20 receptors, decrease the population of the pre-B, immature B, as well as the mature B cell. Whereas belimumab is an anti-B lymphocyte stimulator antibody. The B lymphocyte stimulator are soluble receptors in the plasma, which attach to the receptors, which is the BAF receptors on the mature B cell and the memory B cell, and leads to their differentiation into plasma cells. Where various trials have been employed for evaluating rituximab in SLE, the landmark trials being the Explorer trial, which was used in non-renal moderate to severe SLE, which showed that there was no significant difference between the placebo and the rituximab group, and the Luna trial, which was in active lupus nephritis patients with the endpoint being a complete or partial renal response in 52 weeks, again having no significant difference between these two groups. Whereas belimumab has been in the foray since 2010, with Bliss 52 coming in 2010, Bliss 76 in 2011, Bliss subcutaneous in 2017, and the recent Bliss lupus nephritis trial in 2020, all of them being a positive trial and leading to the employment of belimumab in SLE treatment. So why do we need to combine these two? Though belimumab has been shown to improve renal outcomes as well as the disease activity, decrease the disease activity in SLE patients, still it hasn't been able to control the disease or make the patient go into remission. Therefore, we need some combination therapy to have a better SLE care. Rituximab, as we saw, had negative trials, and various have been postulated for these negative results. One was that after rituximab, there's an increase in B lymphocyte stimulate level. This increases the survival of the autoreactive B cells. Belimumab, by inhibiting this increase in B lymphocyte stimulate level, might help have a synergistic effect. Similarly, rituximab does not act on the tissue resident B cells. Belimumab causes the B cells from transmigration from blood into the tissue and prevents the B cell from being retained at the tissue level. Therefore, when belimumab is administered before rituximab, this might lead to memory B cells coming into the plasma, and administration of rituximab might lead to a more decrease in the memory B cells level. This was the rationale behind this study. already two trials evaluated belimumab plus rituximab. However, they were phase 2 trials. One was the Calibrate trial, which came out in 2020, in which the primary endpoint was the change in B cell repopulation dynamics at 48 weeks, and it showed that rituximab plus belimumab delayed the B cell repopulation. Similarly, a Beat Lupus trial, which came out in 2022, with a primary endpoint of reduction in anti-DSDNA antibody level, showed that their belimumab plus rituximab significantly reduced anti-DSDNA antibody level. Therefore, this trial was efficacy and safety of sequential therapy with subcutaneous belimumab and one cycle of rituximab in patients with systemic lupus erythematosus. This came out in August 2024 last year and was published in Annals of Rheumatic Diseases. So, achieving disease control without corticosteroids is still an unmet need, but no previous RCT has previously employed these endpoints. Let us look at the methodology of the trial. So, this was a phase 3 multicentric double-blind placebo-controlled 104-week study. The population was adult patient more than 18 years with an active moderate to severe SLE defined by SLEDAI 2K score of more than 6. Intervention was subcutaneous belimumab 200 mg per week along with rituximab 1 gram IV 2 weeks apart. Comparison was with a belimumab placebo group, and there was also an open label reference standard therapy group. Outcomes was disease control at 52 and 104 weeks and remission at 64 weeks. And the time period was 104 weeks, which included 52 weeks of treatment and a 52 weeks observation period. The inclusion criteria included patients more than 18 years of age with SLE diagnosed based on ACR 1997 classification criteria, ANA or a dsDNA positivity, and a SLEDAI score of more than 6. Whereas patients with severe lupus nephritis or severe active central nervous system lupus were excluded from the study. The patients were centrally randomized in 1:2:1 ratio in 3 groups. The randomization was made so that more people go into the belimumab rituximab group so as to increase the power of the study. They were stratified at baseline to remove the confounders on the basis of SLEDAI score less than 9 or more than 10, whether they were on immunosuppressant or off immunosuppressant, or whether their prednisone dose was less than 10 or more than 10. The groups were first group being a belimumab placebo group, second was belimumab rituximab group, and the third was an open label belimumab standard therapy group. So let us look at the study protocol. Initially 52 weeks was a treatment period, followed by 52 weeks of observation period in which there was clinical assessment at week 60, 64 and 8 weeks after. NSAIDs, antimalarials and corticosteroids less than 5 mg per day were allowed during this observation period. However, if any time the patient had corticosteroid dose more than 5 mg per day, or any immunosuppressant was added or increased in the patient, or the patient received open label belimumab, it was considered a treatment failure. The first group, belimumab plus placebo group, was given belimumab 200 mg per week for 52 weeks and an IV placebo at weeks 4 and 6, which was followed by a treatment-free, double-blind observational phase in which NSAIDs, antimalarials, and steroids less than 5 mg per day were allowed. The second group was belimumab rituximab group, which included belimumab 200 mg per week, and patient received IV rituximab 1 gram at weeks 4 and 6, which was again followed by a treatment-free double-blind observational phase in which again NSAIDs, antimalarials, and steroids less than 5 mg per day were allowed. The third group was the belimumab standard therapy group, in which for the entire 104 weeks, the patient received belimumab 200 mg per week plus standard therapy, which was an open label group, and reduction of immunosuppressant was allowed as per the discretion of the treating physician. The primary endpoint was the disease control at 52 weeks. The disease control was defined at a SLEDAI score of less than 2 without immunosuppressants and a steroid dose of less than 5 mg per day. There were two major secondary endpoints. First was a clinical remission, which was at 64 weeks, which is defined as SLEDAI score of 0 without immunosuppressant and without any steroid use, and the disease control at 104 weeks, that is at the end of 52-week observational period, which was SLEDAI score less than 2 without immunosuppression and a steroid dose of less than 5 mg per day. Along with this, the study also evaluated other secondary endpoints, which was the analysis of the primary endpoint by the baseline characteristics of the patients, the duration of the disease control in the patient, time taken to get disease under control, time taken for clinical remission, the change from baseline in the SLEDAI 2K score, proportion of patients achieving low lupus disease activity state, and the biomarker endpoints including IgG, dsDNA, C3, C4, and B cell repopulation. So the study started at At 4 weeks, the immunosuppressions were stopped in the belimumab, rituximab, and placebo group, and first dose of IV placebo or rituximab was given to the patients. At 6 weeks, the second dose of IV placebo or rituximab was given. 12 weeks, the steroid tapering was started in all the groups. At 26 weeks, steroids were tapered to less than 5 mg per day in all the groups. At 52 weeks, belimumab was stopped in the rituximab and the placebo group. And the primary endpoint, that was disease control, was evaluated. At 64 weeks, the secondary endpoint, that is disease remission, which is SLEDAI of 0 without steroid and without immunosuppressant, was evaluated. And at the end of 104 weeks, the secondary endpoints like disease control at 104 weeks and other minor secondary endpoints were evaluated in the study. The non-responders were defined if they had a prednisolone dose of more than 5 mg after week 26 in any of the groups, if there was reinitiation of immunosuppression in the belimumab, rituximab, or the belimumab placebo group after week 4, if there was increase in immunosuppression in belimumab standard therapy group after week 12, or if the patient withdrew or missed any assessment, hence the data collection was not possible, the patient was considered to be a non-responder. The statistical analysis. The assumed response rate was considered to be 10% in the belimumab placebo group, which was based on historical data, which showed in the Bliss 52 and 76 trial, whereas the 35% response rate was assumed in the belimumab rituximab group. This was assumed because no trial to date has published any assumption of having a disease control. So a 35% disease control was considered to be as very clinically significant in SLE care. Therefore, if the rituximab belimumab group give us a response rate of 35%, which will be very significant. The target with a 98% power to detect this 25% difference and significance level at set at 5%, the target population sample size came out to be 280 patients. The primary and secondary endpoints were tested sequentially. Sequentially testing was done because they had a lot of secondary endpoint. So to decrease the chance of having any secondary endpoint coming out positive by chance, so that is to decrease the chance of getting a false positive, they were tested sequentially in way that if the previously tested endpoint was positive, then only the next endpoint was tested. The logistic regression was adjusted for baseline to remove the confounding factors of SLEDAI score, immunosuppressants use, or prednisolone dose, and finally to see whether the treatment group had any difference. The results. So, the belimumab placebo group had 72 participants, the rituximab group had 144 participants, and the standard therapy group had 76 participants. At the end of 104 weeks, with around 20% dropout in the study, 55 participants remained in the placebo group, 114 in the rituximab group, and 57 participants in the standard therapy group. When considered the intention to treat population, 29 patients are excluded from the modified intention to treat population in the standard therapy group because the assessors which have been blinded based on a random laboratory report. Therefore, at the end of the study, the modified intention to treat population took 72 n equals to 72 in the placebo group, 144 in the rituximab group, and only 47 in the modified intention to treat population group in the standard therapy. So looking at the baseline characteristics were evenly matched in all the three groups, whether we look at the region, whether we look at the gender, age, ethnicity, or a SLEDAI 2K score. The mean SLEDAI 2K score of the study was 10. The biomarkers were equal in all the group, and the mean glucocorticoids dose was 10 mg per day. Immunosuppressants were being used in around 50% of the patient, with the most common immunosuppressant being an anti-malarial. The primary endpoint. So at the end of the study, the primary endpoint, the disease control at 52 weeks was achieved in 16% of the placebo group, 19% of the rituximab group. And however, this was not statistically significant. Of note, even the belimumab standard therapy group had around 25% patients which had achieved disease control. Similarly, the disease clinical remission at 64 weeks, which is defined as SLEDAI of 0 without steroid and without immunosuppression group, was present in 5% of the placebo group, 6% of the rituximab group, but it was still not statistically significant. And a disease control at 104 weeks was 6% in the placebo group and 11% in the rituximab group, again being a non-significant. When we look at the components of what was controlled at 52 weeks, the belimumab rituximab group had higher chances of having a clinical SLEDAI score of less than 2 and not having any immunosuppressant use and having a steroid dose of less than 5 mg per day. However, none of this was statistically significant. This is a forest chart showing the disease control with the help of a baseline characteristics in the patient. The first row shows the overall response rate with an odds ratio of 1.27 group in the rituximab group as compared to the placebo group. However, it was not statistically significant. Neither were any other baseline characteristics statistically significant. However, when we look closely, the people having a baseline SLEDAI score of more than 10 or a positive anti-DSGN antibody level or a steroid dose of more than 10 mg per day or a low C3-C4. In all these patients, the odds of achieving remission was higher in the rituximab group as compared to the placebo group. When we look at the duration of disease control, the mean duration of longest disease control was significantly greater in the rituximab group, being 105 days in the rituximab group compared to 60 days in the placebo group, which was statistically significant at week 52. However, when evaluated at the end of study, that is week 104, it was not statistically significant, though the people in rituximab group had a mean higher than the people in the placebo group. Similarly, when we look at the reduction in SLEDAI 2K score, the SLEDAI 2K score the reduction was statistically significant at week 104 with around minus 1.6 in the belimumab, minus 7.2 in the belimumab rituximab group compared to minus 5.1 placebo group. However, it was not significant at week 52 and week 64. The odds of achieving low lupus disease activity score, though the patient with rituximab, higher proportion of patient with rituximab had low lupus disease activity score at week 52, 64 and 104 week, it was not statistically significant. Similarly, when we take the time to first modified severe SLE flare index, the SLE flare index was modified such that the people, it was included patients who had a SLEDAI index of more than 12, along with any of the patient who had a treatment failure in the form of increase in steroid dose to more than 5 mg or use of any immunosuppressant. So the time to severe SLE flare, though the proportion of patient having severe SLE flare was lesser in the belimumab rituximab group at 52 weeks and also at 104 weeks, it was still not statistically significant. This was a post-hoc analysis conducted to see whether the patient having high proteinuria responded well to the rituximab group. In this post-hoc analysis, around 75% of the patients with a belimumab rituximab group responded had returned to baseline or normal protein at week 52. However, this was still not statistically significant because the small sample size in this population. When we look at the biomarkers endpoints, the serum IgG levels was significantly low in the rituximab group at 152 at 52 weeks. It decreased in all the three groups with a higher proportion of decrease in the rituximab group. However, the serum IgG levels increased after the belimumab was stopped, but still did not reach the baseline. Similarly, the anti-dsDNA level was significantly lower in the belimumab rituximab group with a significant difference at week 52 and week 64. However, the difference at week 104 was not significant. Similarly, the change in baseline C3 at week 52, 64, and 104 weeks was higher in the belimumab rituximab group. It was significant at the 52 and 64 weeks. However, at 104 weeks, it was not significant, though it was more as compared to the placebo as well as the standard therapy group. The C4 levels were again significantly lower in the rituximab group at week 52, 64, and 104 weeks. When evaluated the safety was done by descriptive analysis, seeing the proportion of patients having a serious adverse events or a significant adverse event in this group. As we can see, the proportion of patients having infestation, or any other adverse event was similar in all the three groups. Whereas we see the serious infection infestation rate, the proportion of patient was higher in the rituximab group as compared to the standard therapy or the placebo group. There were in total 3 deaths, one death in the placebo group with the patient having a cholangiocarcinoma and 2 deaths in the rituximab group. One group was because of sepsis and the other patient had a sudden death with cause not identified. So, conclusion, the primary outcome of the study, the addition of rituximab to belimumab, did not demonstrate superiority over belimumab alone for achieving disease control at week 52 weeks. And the secondary outcomes, there was no significant difference in the clinical remission or disease control at 64 and 104 weeks between belimumab rituximab and the belimumab placebo group. When we look at the strength of the study, it is the first randomized trial in SLE to explore sequential B-cell targeting with belimumab followed by rituximab. The BEAT lupus trial evaluated rituximab followed by belimumab Therefore, this is the first trial with a sequential therapy in which the belimumab was given first, followed by a rituximab. There was stringent and clinically meaningful endpoints which are necessary in the form of disease control and remission of corticosteroids and immunosuppression, which are the target of disease control in SLE. It was a global multi-centric trial. There was strict corticosteroid tapering regimen to less than 5 mg per day and immunosuppressant withdrawal, which will be helpful in reducing the long-term treatment-related toxicity in SLE. It included a 52-week observation phase in which the patient was off immunosuppressants. And there was a detailed safety assessment with safety profile of the combination therapy, which showed that a combination of rituximab plus belimumab did not have significant more adverse events. And the subgroup analysis had potentially identified patients that may benefit most from the combination therapy. When we look at the limitation of the study, the stringent endpoint definition may reduce the overall response rate and might have obscured the potential benefits of rituximab and belimumab trial. The small subgroup sizes made it difficult to analyze the subgroup analysis. There was a high dropout rate and a high treatment failure rate, mainly because of the stringent endpoints which were defined in this trial. There was a limited observation period for sustained out, and there was no continuous therapy given. So we don't know whether a sustained therapy with this will have an outcome. There was no real world comparison. Though the belimumab standard therapy arm was taken, it was an open label trial, and the statistics were not compared with this. It was only a descriptive analysis of that arm. There was a good biomarker response. However, it did not clinically translate into a clinical response. And the evaluation was done at 52 weeks, which is 46 weeks after a dose of rituximab, at which the action of the rituximab might have already gone away. So I'll be critically appraising this article based on a critical appraisal skills program checklist. So when we look at the validity of the study design, so did the study address a clearly focused research question? Yes, it evaluated the efficacy and safety of belimumab plus rituximab versus belimumab alone in patients with SLE. The research followed a PICOT framework, which has been described earlier. Was the assignment of the participants to treatment randomized? Yes, it was randomized. Where all the patients who entered the study accounted for this conclusion? Yes, the intention to treat population took all the patients who started the study, and the patients who had missing data or lost were taken as a treatment failure. Where participants, clinicians, and outcome assessors blinded? Yes, it was a double-blind study. In the placebo and the rituximab group, it was double-blind. However, in the standard therapy group, it was an open label therapy group. It was not included in the analysis, and also the investigators who were assessing the therapy in the standard therapy group were blinded. Were the study group similar at the start of the trial? Yes. And apart from the intervention, were both groups treated equally? Yes. Were the effects of the intervention reported comprehensively? Yes. And the precision of the estimate of intervention or treatment effect reported? Yes, they had given p-values for statistical significance. They had given confidence intervals for precision of the study, and they had mentioned the hazard ratios and the risk differences. Do the benefit outweigh the risk and the cost? No, the combination therapy did not prove a substantial addition benefits over belimumab alone, and there were safety concerns in the form of increased risk of major infection in the rituximab group. Then the study be applied to a local population partially because yes, it was a multi-centric study and the 10% of the population taken was Asian population. However, access to belimumab is a challenge in a local. Where all important clinical outcomes considered, yes, they evaluated the disease activity, the steroid reduction, and the safety outcomes, which are all relevant for SLE management. And will the intervention provide more value than existing treatment? Since the trial was a negative trial and it did not show superior efficacy over belimumab alone, this intervention does not provide more value than the existing treatment at present. So way forward will be a trial with a less stringent primary endpoints, which might allow continuation of immunosuppression, which is a real world practice, to assess whether the continuous administration of belimumab plus rituximab has benefits over the standard therapy. The trial based on subgroup of population which showed greater response in this combination therapy. The evaluation of this combination therapy in severe lupus with a less stringent endpoints, exploring alternative B-cell depletion strategy like obinutuzumab instead of rituximab, and identifying the predictor of response to belimumab plus rituximab. Thank you.
Varsha, you're muted.
Thank you, Dr. Ashish. Good presentation. He's taken us through the entire trial. I invite some comments and questions for the presenter from our faculty members, Dr. Sushant and Dr. Sanat.
Hi Ashish, can I go first?
Yes,
Yes,
sir.
please.
Okay. Hi, really good presentation. I love the critical appraisal at the end. That's a good idea to do for everything that you're reading, actually. So, it was a good study. It's good to go through a negative study also. I feel what often happens is that we disregard negative studies, and we really have to look for answers, or let's say take home messages from negative studies, because they have a lot. So I mean, essentially they've worked for 5 and 10 years, and one negative study does not um, wash away all their efforts. So it's a good hypothesis. It's hypothesis driven. There are multiple things that came positive also, in the sense that duration of a good clinical response was longer, so more sustained, which was good. And it sort of opens food for thought, in the sense that, do you really want to include these two together? And it's good to say that we don't know. So if somebody asks you tomorrow what you'll do, if will you combine these two in a patient, what do you think you'll say? If a, so
Sir,
it's interesting to try and translate it to the
Translate
clinic.
this
So
into-
if a patient asks you, or a patient's relative has read this article and says that I've read somewhere where belimumab and rituximab can be combined, what will you tell them? And this answer yours and mine will be different, because practice styles are different, but it's interesting to think about how you will translate it.
so if it all depends on the stage the patient is at. If the patient is already on a severe, on having a severe lupus, despite being on many immunosuppressant, yes, I will tell them that despite you receiving the standard therapy, you are still having a severe lupus nephritis. So we might go for an option which is still in the trial phase, which includes a combination of belimumab plus rituximab. Though this trial has come out to be negative, but the safety of this trial showed that you do not have more adverse effects. And since the duration of disease control was higher in this study, and we will not follow the stringent methods which was used in this study, this might benefit you in the trial. So it will be the final decision of the patient. But yes, if the patient is not controlled on standard therapy and having a severe lupus despite exhausting all the options, I will give him an option of using belimumab along with rituximab.
So were the patients in the trial severe lupus? What kind
Uh,
of patients were they?
no, sir. Since the study evaluated the primary
They
endpoint,
weren't very
They weren't,
severe.
so they had actually
Yeah.
eliminated those,
yes, sir,
excluded.
because the study, the endpoint
Yeah,
of the
they
study,
weren't very severe lupus. So in fact, I would not use it in that population that you're saying. They weren't very severe lupus. I would think the goal of using this combination in the clinic would be if somebody wants to try and reduce corticosteroids to zero. There are many patients who want to do that. There's a huge behavioral aspect around using corticosteroids, both in patients as well as doctors. So that could be a reasonable maybe goal of using it in a patient, if you're going to try and use it. I would not think that very severe lupus is where you might use it based on this study.
Yes.
Right. Okay.
Okay, Dr. Sushant.
I'll ask one more question.
Yes,
So
yes.
what new did you learn in the methodology section? So what do you think was interesting in the methodology of this trial?
So
Do you feel anything was new?
yes, sir. The sequential alpha testing was something new which I hadn't come across till now. That was something I had learned new, that when we have a lot of secondary endpoints, to remove the alpha error, to remove it coming to a false positive, you can have a sequential alpha testing. So that was something which was very new for me. Similarly, a logistic regression model, though we have seen in many studies, which was something to learn in detail, was something new for me in this.
Okay, good, nice.
Dr. Sushant, any comments from you?
Yes, ma'am. So, Dr. Ashish, wonderful presentation. Thank you. A quick question, continuation from where Dr. Sanath left, probably. This trial excluded severe lupus nephritis, CNS lupus. How do you see that? Is that Would you see that as a limitation of the study? Do you think they did the right thing? Was that what is the rationale there that you see?
It cannot be counted as a limitation of the study. The rationale behind this was they evaluated the endpoints were very stringent. They evaluated disease control at 52 weeks, which was SLEDI less than 5, less than 2, and a steroid less than 5. And they evaluated clinical remission, that is patient being off immunosuppressant and off steroids at 64 weeks. If they had taken patient as having severe lupus or severe lupus nephritis or CNS lupus, then definitely to have these endpoints achieved in this patient will be very low. Therefore, this rationale behind the excluding the patient with severe lupus was basically the endpoint which they had defined.
Right. And while in clinical practice, as the previous discussion, we tend to use drugs more often when we get a severe lupus. So the evidence there is missing. So I think you also said it in your future direction that probably a trial more on severe lupus should be thought of. But I agree with you. Mixing up the two population cohorts would have had a heterogeneous population and would have made it even further difficult to figure out the endpoints. Thank you so much. No further questions from my side now.
So Ashish, one more question from my side.
Yes, ma'am.
Any other way forward that you can see in this? Like in the biomarker group, when it was studied, what was found? What did they find? Did they find something more significant than in clinical translation?
And the biomarker group in this trial as well as in the Calibrate and the Beat Lupus trial showed that the patient to have a good clinical response in the form of decrease in anti-DSDNA level, increase in C3, C4, and IgG, decrease in IgG. However, in all these three trials, this biomarker response did not translate into an actual clinical response. Similarly, at the end of trial, when they saw the B cell repopulation, they saw that CD20 and CD27 positive, that is memory B cell depletion, was more with the rituximab and placebo group combination. However, since the trial evaluated them at 52 weeks and 104 weeks, eventually the subset of population of CD20 and CD19 was almost equal in all the three groups. This shows us that since they had given rituximab at 4 weeks and 6 weeks and evaluated at 52 and 104 weeks, they might have repopulated. So a future trial in which a rituximab given at 6 months of the therapy or a continuous rituximab therapy might give us a better result in this population.
Yes, that's correct. And biomarkers did show a significant reduction, I think, at 52 weeks, but not at
Yes.
104 weeks, right? Any other faculty wants to comment on this? Dr. Rohini? Rohini, ma'am?
No, I
Do we
just
have-
felt, I just felt that if they had done an evaluation at 26 weeks or 30 weeks, they may have had a better result in the main group, that is the rituximab and belimumab group, because we expect the rituximab effect to wear off by 52 weeks. So I thought that was one of the things they could have done, the evaluation at an earlier point in time. And then in the real world, one would obviously repeat the rituximab
Yes.
prior to an evaluation at 52 weeks. So perhaps that is something which might give a better outcome compared to what they got.
Yes, I think they used too stringent endpoints.
No, the
in-
endpoints and also the way they use rituximab. That is only, and then the evaluation is at 52 weeks. So
Yes.
you don't expect the retux to probably last till that 52 weeks, So I thought
Yes.
that could have been altered. But so that was my thought on this study.
Yes, so I think this combination cannot be given up on completely. Maybe it just requires to be tweaked around.
Right.
Any further questions or comments? So I think why we chose this paper, although it was a, as Ashish said, negative study, but I think negative studies do have they do give us a way forward. We need to assess why they went wrong or what the methodological limitations were. So in this case, I think, what do you think was the main methodological limitation, Ashish?
The main methodological limitation, I think, was eventually taking the assumption which eventually turned out to be the wrong. They had taken an assumed response rate of 35% in the population of the rituximab group. However, they got only a 19% response rate. So that eventually led to a sample size depletion and a low sample size and eventually led to a non-significant study. Other major endpoint, I think, was, as ma'am said, giving a rituximab at 4 and 6 weeks and then assessing the patient at 52 and 104 weeks, by which time the effect might have already gone, with the two stringent endpoints to be taken in the
Yes,
patient.
basically they've removed all immunosuppression. They've reduced the steroids and
Yes,
not
ma'am.
given rituximab. I think that was probably what they wanted to approximate was a treat to target kind of situation, but that's not practical in our scene. Yes. Sanat, anything further you'd like to add?
No, that's all. It was really good. Very good presentation.
Kavita ma'am?
Yeah, I think it was a excellent beginning, our first journal club, and very well presented, Ashish. And you went through all the entire steps of presenting to the critical appraisal. So we should continue this, and I think our next journal club will be somewhere in
It'll be
June,
after 3
July.
months.
Yeah, every 3 months. So we hope to continue this activity. Thank you so much, Varsha, Dr. Sanat, Dr. Sushant, and Dr. Ashish. Thank you, Roni ma'am, for being here today. And your student is very good. And I think Ashish, please stop sharing your slides.
I think, ma'am, we have one question about can Benelista decrease the IgG levels?
Okay.
So yes, in the study, they saw that at 52 weeks, there was very significant decrease in the IgG level in the Belumab, both the Belumab groups. And as soon as the Belumab group was stopped at 54 weeks, the IgG levels started increasing, but they still didn't reach the baseline 104 weeks. So definitely Benelista decreases the IgG levels.
Okay.
Yeah.
I have a suggestion, Kavita and Varsha.
Yeah, sure.
Maybe Sanat and Sushant can be asked to take a talk on, how to read a paper, so that it's for everyone. Then this is sort of one student, and they guided him, but you can have a general talk as well as we keep as part of the MRA meeting.
Yes, sure, ma'am.
Yeah.
There's one more question in this, I think. Varsha, can you see that?
Yeah, so at which IgG level we should hold Benelista? 1 second. Yeah, at which IgG level we should hold Benelista or replace IVIG? That's another question that has been posed.
I actually don't know the answer to this question, ma'am, but I think it will be the same as we use in case of rituximab. That is the IgG level of less than 200, or a IgG level of less than 500 with a severe infections. In this place, we should consider replacing IVIG, but I think you will be able to better answer this question.
Replacing with IVIG is what he means, I think.
Yes, ma'am. Replacing with IVIG. So I think a level of less than 200 or a level of less than 500 with having a recurrent infection should be the target in replacing IVIG in patients with a low IgG levels.
The same as happens with rituximab. So.
Yes, that's how you assess the levels.
Okay.
Okay, so
Okay.
I think we're done with the questions. Thank you so much. This was a great attempt by Ashish, very well read, and you've critically appraised the paper well.
Thank you, ma'am.
Okay, so Varsha,
Thank
you
you,
can
Sanat
decide
and
who will,
Sushant.
you can decide who
Thank
will
you.
take the talk on how to read a scientific paper next time, sometime.
Okay.
We go
Yes.
on to the second part of this student-teacher interface today. I take Dr. Madhumita ma'am, will you start sharing your slides just to be
Yes.
sure? Yeah. Okay.
I'll just take your leave. I have some function at home.
Yeah,
So
okay,
I'm
Dr.
sorry.
Thank you,
Hi,
ma'am, for
hi,
joining. Thank you.
Hi, Madhumita, and I'm sorry I
Hi,
can't stay
Rohini.
on. Yeah.
Yeah,
Okay.
we go a long way.
Yes,
21 years.
yes.
Anyway,
Good to see you. Yeah, but I'm
Okay.
sorry I'll have to leave now.
No
So
problem.
thank
No
you,
problem.
thank you. It was a nice.
On behalf of the Maharashtra Rheumatology Association, it gives me great pleasure to welcome Dr. Madhumita Das, Professor and Head, Department of Medicine, Guwahati Medical College, Assam, So we are really happy to have you here. She did her MBBS, MD, and trained in rheumatology at PD Hinduja Hospital, Mumbai. And she's been practicing rheumatology for over 20 years. She's affiliated, she's a part of many trials, and she's a member of many academic committees and a PG guide for many years. She has been the ex-president of the IRA East Zone. She delivered the presidential oration of the East Zone Rheumatology Association at Kaziranga in 2023 on the subject of gut microbiota in connective tissue disease. She has numerous publications to her credit. She's a good friend and a good orator, and I hear from her students she's an excellent teacher. So today she'll be talking on a very important topic for students and practitioners: pregnancy and systemic lupus erythematosus. Welcome, Dr. Madhumita. Over to you.
Thank you, Dr. Kavita, for the wonderful introduction. And actually, I feel humbled to be invited to this forum as a speaker because I'm basically practicing medicine with rheumatology as an area of interest. And my subject today is, of course, as you said, pregnancy in SLE. And before I go on to the subject, I would like to make it clear that my presentation is basically targeted for the postgraduate students. So it's relatively basic, simple, and I hope they will be benefited.
Yeah.
So let's get going.
Yeah. Thank you.
It's not moving. Yes. So just brushing up the new EULAR criteria, ACR criteria for the classification of SLE, we are all aware about the different domains and the amount of importance given to the arthritis and the serositis. I mean, every individual domain. And one important thing that we should remember here, that this is the classification criteria. This is not the diagnostic criteria as it is for our juniors to remember, because the diagnosis is, of course, based on the ANA, and the presence of the other components tells us about the classification criteria of the disease. And a patient must have more than 10 points to be classified as active SLE. Now, next. So what are the pre-pregnancy challenges before a woman gets pregnant who already has SLE? If the woman is SLE in remission or stable, low disease activity, we are comfortable to allow her to plan a pregnancy and go ahead and be on guard like with all other pregnant women. And those who have SLE with active disease, women should be actually encouraged to postpone pregnancy, to use contraception, and to plan the pregnancy while it is in remission. But if there is, on the other hand, if there is evidence of severe organ dysfunction, then we should better ask them never to get pregnant. Next, when to conceive. If the lady has severe lupus flares within the last 6 months, we should wait for longer. Severe restrictive lung disease, no. Heart failure, cardiac, chronic renal failure, as we have just said, that is severe organ dysfunction. Stroke within the previous 6 months. Previous severe preeclampsia or HELLP syndrome, that also can be a contraindication for pregnancy, and severe pulmonary hypertension. Challenges met during pregnancy for SLE patients. Pregnancy is an additional risk factor for any woman. So all the risk factors of a normal pregnancy are there, together with the additional factors of the disease. And most important is SLE flare can occur during pregnancy. If it so happens, fetal outcome is poor. Safety of drugs should always be kept in mind. And if the disease is in remission, usually fertility is not affected, unless drugs have been used in the wrong way. Outcome of pregnancy in SLE patients, what happens? If the disease is in remission, no flares during the pregnancy, then the outcome is good. Otherwise, disease active, outcome is usually very difficult to predict and usually bad. So, what are the things that we should evaluate once a woman with the disease in remission, hopefully, has got pregnant? Initial evaluation in the first visit should be to know the status of the disease, where the basic things would be a routine examination of blood, urine, CBC, ESR, all the inflammatory markers, the dsDNA titer, the complements, serum creatinine, 24 hours urinary protein, if possible, creatinine clearance, the Rho, La, the blood glucose, lipid profile, Coombs test, all the serology for all the viral diseases, liver function test. These are specifically to be kept in mind over and above the other recommended tests for high risk pregnancy, like, thyroid dysfunction, GTT, all that. Now, investigation for assessment of disease activity, even if the patient is clinically in remission, diseases and the medication is in the optimum dosage, we should be very careful and very intricately look into every single organ dysfunction. For cardiac, we look for pulmonary hypertension, valvular heart disease, cardiomyopathy. So we have to do an echo over and above the ECG and all other cardiac testing. Respiratory, we look for the pulmonary fibrosis and other forms of restrictive lung disease, which can occur either because of the disease or treatment. Renal, yes, we have to look for proteinuria, 24 hours urinary protein, other evidence of lupus nephritis in the form of hematuria, hypertension, active sediments in urine, and renal function tests. Pre-existing renal function test is very important to keep documented to look at the progression of the changes during the course of the pregnancy. Then hematological and immunological testing, most important, we have to be aware that pregnancy per se is a prothrombotic situation, and besides the disease can cause a lot of thrombosis problems. So we have to look for the antibody profile, antiphospholipid, anticardiolipin, anticoagulants, anti-dsDNA, Rho, La, complements, so that we can take adequate precaution to prevent abnormal thrombosis. Now, so these are the factors that actually affect the outcome of pregnancy in an SLE patient. As we've just said, the disease activity, presence of lupus nephritis, the worse the lupus nephritis, the worse the outcome. Rho and La, we will be coming into, we all know we need extra precautions. Antiphospholipid, yes, more precautions, more drugs to be used. Cardiac and lung involvement, depending on the stage of involvement, would affect the outcome of the pregnancy. The other thing is appropriate medication. The guiding principles of the European League Against Rheumatism says the significance of family planning is very important. The goal is to minimize injury to the fetus. Weighing the dangers of the treatment and the danger of the illness, we have to plan the pregnancy in the proper timing, and a multidisciplinary involvement is crucial for determining the outcome of the pregnancy. The drugs that we can be using throughout the pregnancy are tacrolimus, cyclosporin, hydroxychloroquine, azathioprine in the optimum dose. There are some people who believe that it can cause a lot of bone marrow involvement, even otherwise. Low dose steroid, very important. The dose monitoring is extremely crucial. Higher the dose, it gets difficult with the baby. And to the greatest extent feasible, steroid sparing immunosuppressant are better to be used. Antihypertensives should be used as per choice, usually labetalol, methyldopa, nifedipine, hydralazine. So SLE patients suffer from different kinds of, the same kind of pregnancy problems as non-SLE patients, but the two major additional problems that we need to highlight is there is an increased risk of the normal pregnancy complications in these patients. And secondly, we have to be on guard for SLE flares during pregnancy, because it can be so subtle, just worsening of few clinical symptoms and a falling in the complements, even within the normal range, can actually warn a flare during pregnancy. So, common pregnancy-related complications that can occur in the antenatal period, that is pregnancy-related hypertension, preeclampsia, eclampsia, that is actually a challenge for the treating doctors to differentiate between preeclampsia, eclampsia, HELP, and SLE flare, antepartum hemorrhage, IUGR, prematurity, abortion and stillbirths, and gestational diabetes, both otherwise and because of the use of steroids. Other maternal complications are infection, deep vein thrombosis, pulmonary embolism, as we know that it's a prothrombotic state. Cerebrovascular accidents are sometimes seen, and pulmonary hypertension. So maternal lupus flares are something we have to be very much on guard. Flares can be defined as unpredictable bouts of disease going up in spite of it being in remission in the past. Flares increase maternal morbidity and risk of premature labor, and therapeutic issues at that point are very important concerns. Flares can occur throughout pregnancy. So it is like, we generally say that eclampsia, preeclampsia is after 20 weeks of pregnancy, but flares could occur anytime. So we have to be very cautious. Generally, the symptoms could be mild, like arthritis, fatigue, cutaneous manifestation. Exacerbation of SLE with major organ dysfunction like CNS and kidney dysfunction could occur 5% of CNS and 46% of kidney dysfunction during pregnancy. And this is what I just said, and a fall of serum complement level, even within the normal limits, could warn an SLE flare. So, monitoring of serum complements and dsDNA titers are very important. Now, how do you distinguish between pregnancy changes and SLE activity? In a normal pregnancy, there can be a facial flush, palmar erythema. These are all because of the high estrogen stage. There can be arthralgias, fatigue, mild edema, mild resting dyspnea. But in SLE activity, there will be the rash, which is photosensitive. There could be oral and nasal ulcers. The arthralgia is not just joint pain. There is inflammatory arthritis. There could be fatigue and lethargy beyond just being tired. Edema is more severe, and the dyspnea here could be attributed to not just the anemia and the fluid retention, but there could be pleuritis, pericarditis, and other causes that can cause more of dyspnea. The labs would show that in pregnancy, there is always a mild anemia. There could be a mild anemia, more so dilutional, mild thrombocytopenia, mild increase in ESR, and a physiological proteinuria. Whereas when there is an increase in SLE activity, the anemia could be autoimmune hemolytic anemia. There could be more thrombocytopenia, more pronounced with bone marrow suppression. ESR and the other inflammatory markers could be raised, proteinuria is significant, and there is active urine sediment in the form of hematuria. So this is how we distinguish between preeclampsia and lupus flares and normal pregnancy situation. So in preeclampsia, usually it is after 20 weeks. There could be severe headache, visual symptoms, epigastric pain, hyperreflexia and clonus could be present, abnormal liver function, rising uric acid level is one of the very important things, and signs of hemolysis. But in lupus flares, it could be actually even before 20 weeks to later, anytime during pregnancy. Active urinary sediments, as we just mentioned about hematuria, low or falling complement level, high or rising, increasing level of dsDNA, and evidence of flare in other organs. But in the normal pregnancy, that is not pronounced. Treatment of lupus flares. What happens? Lupus flares should be treated with appropriate dose of prednisolone. So that is the very important thing that we need to keep in mind. Extremely higher doses are usually avoided. IVIG is safe through all the trimesters of pregnancy. Rituximab have been used in certain situations on guard in the early part, in the first trimester of pregnancy, but in the last trimester, rituximab is contraindicated, where it can cause severe immunodeficiency in the newborn. Azathioprine and cyclosporin are supposed to be safe during pregnancy. In non-responders, tacrolimus can be used, but of course, cyclophosphamide, methotrexate, mycophenolate are contraindicated. So what are the things that we need to keep in mind when we are using prednisolone? If we use a higher dose, there is an increased chance of cleft lip and premature rupture of membrane, preeclampsia, diabetes. Azathioprine is safe in the usual therapeutic doses, but sometimes it can cause bone marrow suppression. Cyclosporin is found to be safe, but there are reports of growth retardation. Cyclophosphamide and methotrexate can never be used. Lupus nephritis, lupus pregnancy, nephritis, and eclampsia is an important risk factor for both maternal and fetal mortality complications. Positive associations have been seen with preterm babies, preeclampsia and lupus nephritis. If a woman during pregnancy has proteinuria and hypertension, the interpretation should be made in the light of the renal involvement at the baseline. So it's always better that you plan the pregnancy properly. You have a baseline report of what the urine was and what the other organ situation was, so that whenever there is a change, you can predict the flare and fall in the complement level, as we just said, even within the normal range, or a rising level of dsDNA titer, even within the normal range, actually heralds a flare. Risk factor for preeclampsia is in SLE is after 20 weeks of pregnancy, when the patient is on a higher dose of steroid, meaning more than 20 milligram per day. First pregnancy is always an additional risk factor. Preeclampsia in the prior pregnancy, twin or multifetal gestation, history of lupus nephritis and or hypertension, and history of antiphospholipid syndrome are actually risk factors for preeclampsia in SLE patients. So lupus nephritis and preeclampsia must be actually differentiated. Preeclampsia requires early delivery, whereas lupus nephritis requires a prudent use of immunosuppression. So it is extremely important to be conversant with certain things like the timing. Preeclampsia is always after 20 weeks. And lupus nephritis could actually be at any time, even after 20 weeks or earlier. Hypertension is present, usually could be present in both. Urine active sediments in the form of hematuria is usually not seen in preeclampsia, but very commonly seen in lupus nephritis. Onset of proteinuria is abrupt in preeclampsia after 20 weeks, but in lupus nephritis, it is usually gradual, building up from the baseline. Uric acid level being higher in preeclampsia, in lupus nephritis, it is usually below 4.9. So that is a very important thing to keep in mind. Complement levels are normal in preeclampsia. In lupus nephritis, usually low or falling. Similar are the complement products. Anti-dsDNA titer, if it is preeclampsia, it will be normal. Lupus nephritis, it could actually be going up. Urinary calcium. Thrombocytopenia is more a marker of health, but it could happen pronounced in 20% of SLE patients. Liver function test altered in health, usually normal in lupus nephritis. Kidney biopsy will tell us the details of the pathology. Now, a few words about antiphospholipid syndrome, because that is a major risk factor during pregnancy to be kept in mind and a cause of fetal loss. Recommended treatment is low-dose aspirin and low molecular weight heparin. Osteotic APS has a higher thrombotic risk. Smoking and alcohol consumption should be stopped. Low dose of steroid has been evaluated and found useful in refractory cases, but otherwise IVIG improves pregnancy complications. Pravastatin suggests a beneficial role in women with preeclampsia antiphospholipid. Hydroxychloroquine, an immunomodulator, has very beneficial effects in preventing the thrombotic complications of APS and also in the treatment. As such, hydroxychloroquine should never be stopped during the whole course of the disease, actually, SLE, unless there is a major contraindication. That is a wonder drug. What are the fetal complications that could occur? There could be prematurity, fetal loss, there could be neonatal lupus, there could be intrauterine growth retardation, reduced liquor, there could be fetal distress, premature rupture of membrane, and risk factors of premature delivery are usually antiphospholipid syndrome, active disease at conception, flares during the course of the disease, renal dysfunction, and high blood pressure. So now what is neonatal lupus? Neonatal lupus syndrome is an unusual condition that occurs in when the maternal antibodies, anti-Rho and La, crosses over to the unborn fetus. There is congenital, the main features are congenital heart block, transient cutaneous lupus, cytopenias, hepatic, and other systemic manifestation in the newborn. Complete heart block is a more serious form of neonatal lupus, which affects 2% of newborn of Rho positive mothers and may require use of permanent pacemaker. Recurrence rate is 16 to 20% after the first neonatal lupus in the mother for the second pregnancy. And there could be a mortality from complete heart block to up to 20% in the newborn child. So fetal echo should be done to diagnose heart block. Fetal heart rate should be auscultated, recorded 1 to 2 weeks and every 1 to 2 weeks and referred to a fetal cardiologist if available. And if it is low, below 110, then that is an alarm. If incomplete heart block, myositis, ascites, hydrops is identified, then therapy with steroids and hydroxychloroquine should be considered higher dose if the patient is on a lower dose of hydroxychloroquine. 200 should be reduced to 400. Hydrops in a fetus with complete heart block is, of course, an extremely poor prognostic marker with 100% mortality. The woman should be seen in the first trimester, both by the obstetrician and the rheumatologist. Same as for normal non-SLE antenatal care, more concentration should be given to identify early disease activity. Search for SLE-related pregnancy complications should be kept in mind, and patients suffering from active disease would need additional observation. So what do we do during the subsequent follow-ups? History and clinical examination should be focused on identification of disease flares. So flare is something we have to be always on guard, and the pregnancy-related complications and the distinction between the two. So the labs include CBC, ESR, routine urine, creatinine, the GTT for diabetes, then anti-dsDNA and C3 at the end of each trimester. The biophysical profile scoring from 28 weeks, and women detected to have either Rho or La should have serial fetal echoes between 16 to 24 weeks of gestation, even if there are no overt complications. Measurement of the crown rump length in the first trimester, level 2 scan in 16 to 22 weeks of gestation, growth scan every month and every 15 days if there is preeclampsia. Fetal echo at 22 weeks of gestation is mandatory for women who have Rho or La positive to exclude congenital heart block. Bilateral uterine notch between 20 to 25 weeks is a risk factor for the development of early PET and gestational hypertension. And of course, we have to look into biophysical profile, Doppler, and all fetal close monitoring until delivery. General advice for all SLE patients would be avoiding exposure to sun to prevent flares, and mother should take a low salt diet and balance with other vitamins and minerals. Drugs that should be always safely recommended are folic acid, hydroxychloroquine, low dose aspirin, 75 milligram in our country if antiphospholipid is present and is and if high risk, then we of course have to look for the presence of nephritis, and we might have to go for anticoagulation. Women with previous hypertension, preeclampsia, and other disease activity will need frequent monitoring of blood pressure and urine checks. Women on steroids or with previous gestational diabetes would need have more stringent control of their sugars and more monitoring even if they are maintaining a normal sugar level. Now, what are the situations when you should ask for a medical termination of pregnancy? Fetal complications that can lead to delivery of a handicapped fetus, continuation of pregnancy while at the cost of endangering the mother's life, so high disease activity, or if the patient has conceived while on methotrexate, cyclophosphamide, or rituximab within the last 12 weeks. Intrapartum complications is, a multidisciplinary team, which would consist of the obstetrician, rheumatologist, nephrologist, cardiologist, fetal medicine specialist, and the neonatologist would form the team. We have to be very careful if the woman with SLE, because she can have an increased risk of preterm delivery. If the fetus is at 24 to 34 weeks of gestation, 2 maternal injections of hydrocortisone is given to allow maturation of the lung of the fetus. If the gestational age is less than 32 weeks, magnesium sulfate should be given to allow neuroprotective benefits. And mode of delivery should always be encouraged for normal vaginal delivery because the complications of cesarean section are more in a SLE mother, and more so the long-term implications for future pregnancies is always worse in a post-cesarean section mother. So if the woman is on long-term oral steroids, she should be given intravenous hydrocortisone at least 8 hourly, and women receiving standard dose of low molecular weight heparin should discontinue at the onset of spontaneous labor or elective section, and then it should be continued in the postpartum period. So during the postpartum period, the mother should be watched for infection and disease exacerbations. Treatment of underlying pregnancy-induced hypertension is important. Risk assessment and prophylactic treatment for thrombosis, particularly in women with APS who've had previous thrombotic episodes or nephrotic syndrome. If the woman is on long-term oral steroids, yes, IV hydrocortisone, as we just mentioned, she should be called to the hospital in the postpartum period after 4 to 6 weeks after she is discharged from the hospital. And all women who received antenatal low molecular weight heparin should continue up until 6 weeks postpartum because of the risk of thrombosis in the postpartum period, and also flares up to 6 weeks could be high. Breastfeeding, this is a major issue. Majority of drugs are excreted in human milk in variable amounts. So we have to be very careful. For neonatal perspective, maternal intake of prednisolone should be as less as possible, definitely below 20 milligram. Cyclosporin in standard doses, and weekly chloroquine. If for malaria prophylaxis is what the book says, if the dose of prednisolone is greater than 30 milligram, breastfeeding should be done after the dose of prednisolone. The mother waits for 4 hours and then she could feed the baby, but preferably we want to have the lowest possible dose of steroid. And by the time the blood levels are quite low and limited amount actually is supposed to be secreted in the milk. Contraception, As we know, the disease itself is a prothrombotic situation. So barrier methods are the safest for contraception. Low dose of estrogen and progesterone pills are relatively safe. High dose estrogen should be avoided. OCP should be avoided in antiphospholipid syndrome or high disease activity, Raynaud's phenomena. And the use of intrauterine device is, of course, controversial in these women who are always at a high risk for infection and other complications. Thank you. I think I finished well ahead of time.
Yes, thank you, Dr. Madhumita. Excellent talk. You covered everything right from which patients should not and risk of conception, the entire trimesters of pregnancy, antenatal screening, lactation, delivery, etc. So we can take a few questions. Dr. Varsha, Dr. Shubda is also there. Dr. Shubda?
I did it actually at a very undergraduate level, I think, but I thought that was
I think if
needed.
I had to summarize whatever you said, so screening should be done. The patient should not be in flare when they conceive. So that in that case, the outcome is the best. And how much proteinuria would you permit? Like, if the patient has lupus nephritis and she's better. So she will be on mycophenolate mofetil, steroids, etc., hydroxychloroquine. So if you feel she is in a remission, so proteinuria may never go away completely, so how much proteinuria
Preferably
would you
below
permit?
300 is what the book says.
Yeah. Okay. And you would
Yeah.
switch mycophenolate mofetil to a CNI if required.
Yes.
Varsha?
Yeah,
any
ma'am,
questions, please?
very nice presentation, ma'am, very succinct. I just wanted to ask one thing. A lot of our patients get pregnant while on drugs that they're not meant to get pregnant on, especially MMF.
Yeah.
I've myself had a couple of them like that. Are there any guidelines suggesting, termination of pregnancy or something as drastic, or we just let it happen?
I think the usual teaching is while on cyclophosphamide or on mycophenolate, if the woman gets pregnant and if you get her within the first 8 weeks of pregnancy, you should preferably, tell them that it is best to terminate. But if they just, there aren't any fixed guidelines that I can quote over here. But if they decide to continue, the anomaly scans are the only thing that we can follow up. But, to be safe, the book says that if you get them within the first 8 weeks of pregnancy, that is one of the indications for termination of pregnancy.
So you said to stop the heparin 24 hours before, spontaneous and elective if possible. What about aspirin? You continue till the last day or you recommend to stop earlier?
By the book, yes, 24 hours before elective section, or if it is a
Aspirin.
spontaneous.
No, not heparin, aspirin, ecosprin. They are on a low dose of aspirin.
That's it, 75 milligram. That is also to be stopped at the onset of labor. That is what the textbook says, because it is always best to recommend normal vaginal delivery and to stop both aspirin and heparin at the onset of labor.
And what about dexamethasone if they are having first degree, second degree AV block on fetal echocardiography in a patient who is Rho52 positive?
If there is fetal evidence, fetal congenital heart block, that's what you're saying?
Yeah.
First degree heart block. They have recommended that you give them dexamethasone, and actually that part is usually taken over by a fetal cardiologist, where they might even think of, if it's worsening, even a temporary pacemaker. Otherwise, they cover up with steroids.
Yeah.
You have anything else to add?
No. I think that was not there in your slides. That's why I just asked. So third degree AV block, nothing helps. But if the first, second degree AV block, you can try dexamethasone.
Yeah.
That's
One more
Excellent talk, Madhumita. Very nice.
Yeah, Shubda is online. Yeah.
Oh, Shubhada, hi.
Hi. Excellent talk.
Thank
Well
you,
done.
thank you.
Yeah, Shubda, any questions from your side?
No, I think it was all covered. So All good.
Old friend Shubhada, I wish I could see you. You are not visible.
No, no, एक minute.
Yeah, put your camera on.
Yeah.
Oh, there I see you.
Yeah,
Okay.
Varsha, you were asking something. Yeah.
Yes, ma'am. I just wanted to know about the use of GnRH analogs with cyclophosphamide. So practically, we do not, I mean,
Hmm.
we do not really do it.
I think we do not do it for reasons of cost,
Yes.
but given the
But
best settings,
ovarian preservation, as it were. I mean, so we haven't seen a lot of premature ovarian failure, but I think that needs to be studied more.
that needs to be studied. And
Varsha,
given,
I have used it in couple of patients where the patient was really young. And see, most of the times our problem is planning. If you can plan a cyclophosphamide dose and you can, then you can manage GnRH.
Okay. Okay, ma'am. Because mostly,
And-
even I have given cyclo to really young girls. There was no other option.
yeah,
And now
and
they are
give,
in their age of, they're doing well. And there is no ovarian failure right now. Nothing has happened. But then about infertility, I don't know how to go about counseling them.
but we have seen normal pregnancies and healthy babies in
Yes.
girls who have received cyclo maybe a couple of years back because
Yes.
there was no choice.
Yes.
Actually, if they're given
No,
when they're very
usually
young,
younger the girls, they usually do well. It is
yeah.
especially elderly lady, like
Mm.
if they are approaching 30, 35, and then you have to use cyclophosphamide in a big dose. Nowadays, also because of better availability of drugs, we are using less cyclophosphamide or ular cyclophosphamide. Earlier, when we worked with Dr. Joshi, we used to use 1 gram and we used to go all full,
Yes.
NIH protocol, which was 9, 10 injections and even more because there was nothing else but cyclophosphamide.
Yes,
That
yes.
is the time in elderly primary we used to see a lot of these issues of periods, amenorrhea, and things like that. But
Right.
nowadays, I think with better drugs and better control and use of rituximab, we can manage pretty well. So it is not that much. But if it is affording patient, I think better to take care. Nothing is lost. You still have to explain and counsel the patient, but you can.
I think younger girls, the risk of ovarian failure is less than 1%.
Yeah, yeah, correct.
25. Dr. Jyotsna, ma'am, is there. Dr. Jyotsna? Hello.
Hi. Don't
Dr.
see.
Jyotsna, would you like to give some inputs?
Yeah.
Sorry, I wasn't there earlier. Which kind of a thing? Yeah, the
No,
ovarian failure. I heard that the ovarian failure with cyclophosphamide is really
cyclophosphamide.
less, but we are. I feel in my experience, the most effective drug is still cyclophosphamide. We have used a lot of rituximab and also cyclophosphamide, but between the two, I still feel that cyclophosphamide is more effective.
So you
And
must
I
have
have seen
given,
many infections with rituximab recently, even with tuberculosis.
yeah,
Yes.
so
Yes,
we are
ma'am.
giving cyclophosphamide, even in 1992, 93, when I
Yeah,
was working with
yeah.
you. So how many ovarian failures have you seen? Like, how many patients who couldn't
So
conceive?
I have seen up till now, I think we have about 200 or more such patients, but we have seen ovarian failure in 2 patients.
Only two, yeah. So
Yeah,
the same
yeah,
1%, yeah.
Yeah.
yeah,
So I think we should
yeah,
just take a consent when we give, and
yeah,
counsel.
And benefits are far outweighing. So there is
correct.
no question about that. Yes.
And affordability, kind
Yes.
of affordability is a much relevant question.
Jyotsna, ma'am, have you ever used rituximab in the first trimester of pregnancy?
No, I have not used it.
Okay. Has
Yeah.
anybody used like rituximab in pregnancy, any trimester?
Yeah, I have never used, but they say yes in life-threatening
I haven't
situations.
used, but they have said that for the maternal issue, if you need to use, you can use.
Yeah, like
It is
pulmonary alveolar hemorrhage.
Yeah. And
Yeah,
if you have a successful pregnancy, they do not give live vaccinations to the babies when they're born.
correct.
yeah,
You can
First
yeah.
months, no? First 6 months.
6 months, yeah. Okay, if there are any more questions by anybody or any more inputs? Shubda, Jyotsna ma'am? Okay, thank you so much, Dr. Madhumita. It was
you.
lovely listening to
So
you.
nice to see Madhumita, really. I'm
Yeah,
sorry I'm little late. Yeah,
No, no, thank
nice to
you.
see you.
we will
Thanks
connect
once
again.
again for inviting me to this forum. Thank you.
Thank you for sparing your time on a Sunday, everyone. Thank you, Dr. Madhumita. Thank you, Varsha, for conducting a nice journal club.
Thank you,
Thank
ma'am.
you, Ratna, Shubda, everybody who's been there today. Have a great Sunday. Bye-bye. Take care. Yeah.
Bye-bye.
Thank you,
Bye.
Kavita. So nice.
Bye. Good day. Yeah.
Good day.
আমার বহুত কোনোবা কোনোবা দেখিলো নয়ন ৰাজদীপ নেহা কি লিভ মিটিং